Good morning, everyone, and welcome to session one of our 2025 ACR Annual Educational Workshop. I am so excited that you've all chosen to join us. I'm going to go through a couple of housekeeping bits of information, and then we will get started with our first speaker. So give me 1 second to switch slides, and welcome. All right, as I mentioned, this is session one of this year's 2025 Annual Educational Workshop. And I like to start by just reminding you of who we all are. So our Arizona Cancer Registry is divided into different sections. We've got our operations section headed by Rayanne Robinson, and operations really deals with processing data. So they take in all of the cases that are reported by hospitals, clinics, physicians' offices, pathology laboratories, and even out-of-state data. And they track all of that. They do data processing and quality control. So it is quite a bit. They are a hardworking group over in operations. And with Rayanne, we have Sarah Yeager, Mike Raymond, and Jordan Burge as our data specialists. And then we also have our quality assurance section headed by Michelle Lenzen. And you're going to hear from her a little bit later in this workshop, day 3, I think. And quality assurance section oversees QA studies, audits, and also death clearance. So I'm sure many of you are familiar with getting emails from Michelle when she's doing death clearance looking for information. And she does a great job at all of that. And then I had the training section, and one of those duties is to run this annual workshop. So that's why you're going to be hearing quite a bit from me. And I'm also responsible for overseeing internal training of our ACR staff, making sure that everybody is up to date with current coding practices, and also providing training for our external partners, including our hospital cancer registries. So that is why you are all here as part of that. And I also am responsible for our policies and procedures manual, and also the ACR coding manual that comes out every year. That falls under the training section. And then there's the data section headed by Dana Doyle, our epidemiologist. Dana's actually presenting today, so I'm excited that you guys get to hear from her. And that oversees data analysis, report writing, and cancer concerns. She does a lot of the data requests for us as well. And all of that is overseen by Georgia Yee. And you guys are quite used to working with Georgia by this point. And she will also be presenting not today, but later on in this workshop. So that is who we are. And I think it's a good idea to just remind you guys of the faces and people behind the ACR. So CE information, I am very excited to announce that we have been approved for 8 continuing education hours. 2.75 of those hours are designated category A CE hours. This workshop does not qualify for CEIP credit. I've been asked that quite a bit. We do have an opportunity coming up in December for those of you who are looking to get CEIP credit. And I'll be sending out more information about that soon. To claim your CE hours, you're going to want to keep track of the sessions that you actually attend on the CE tracker. You should all have received that when I emailed you out the slides for today. And after the end of session 4, you'll be emailed a certificate of completion that you can fill out with the CE hours that you've actually earned. So today, here's our agenda. We're right in the middle of the housekeeping section of the presentations. And then today we're really going to be focusing on diffuse large B-cell lymphoma, or DLBCL for short. And we've got a wonderful physician presenter, Dr. Chandra, and I'll be introducing him at the end of this welcome presentation. And that's going to be followed by Dana Doyle talking to us about our statewide cancer burden when it comes to diffuse large B-cell lymphoma. And then I'm going to be doing some practical case scenarios and some coding practice with us all. And that will end with a formal Q&A session as usual. So any questions we don't get to, we're going to send out a Q&A document after the workshop, after session 4, and you'll be able to get answers to your questions. So anything that you would like us to cover, well, I'll get to that in the next slide. So session 2 next week, we're going to be covering QA projects and updates, and Michelle will be presenting on that. And then I'm going to be doing another site-specific abstracting presentation focusing on GYN cancers this year. I'm excited about that. And week 3, if you join us on October 16th, we'll be covering the ACR overview and updates from Georgia, and she'll let us know what's going on at the state level. And then Dana will be giving us a presentation on the overall cancer burden for the state and how your data that you submit to us is actually used. And then Rayanne will be talking to us about what's going on with the operations department and a lot of good things that day. And then session 4, we have Jennifer Rule with NCI-SEER, and she's looking at presenting on some changes coming up with the HEME manual. So excited to hear what she has to say about that. And then I will be following that with data collection changes for 2025 coding and clarifying class of case. So a lot of good education for us this year, and I hope you'll join us for all of that. So chatting etiquette, we have 2 separate chats. We have the Q&A chat and the regular chat. So use the regular chat for any general questions or comments. Communicating with one another, you should all have access to be able to use that chat. We just ask you be respectful, professional, and thoughtful, because what you post is going to be readable to all of us. So the QA chat, please use that specifically for questions that you have related to these presentations, and we will make sure that we answer those. It's just easier for us if you keep them in the Q&A chat so that we can very easily find them. And then any questions we don't get to during the live Q&A session will be answered in that Q&A document that I talked about. So that is all the welcome information that I have for you. And I believe Dr. Chandra is here. Dr. Chandra, would you like to share your slides, or do you want me to run those slides for you? I'm happy to do either way.
I can share the slides. Yeah.
Excellent. Then I will stop my sharing and let you go ahead. And while you're doing that, I will introduce you. Dr. Abhinav Chandra is the Vice President of Specialty Care Services at Onvita Health. He's also the Medical Director of the Onvita Health Cancer and Blood Disorder Center and the Director of Institutional Research for Onvita Health. He holds the rank of Assistant Professor of Medicine from the New York Medical College and has an FACHE certification. He completed his MBA from UCLA Anderson School of Management in 2021. And he's the chair of the Treatment Steering Committee for the Arizona Cancer Coalition. So that's how he's had the chance to work with some of our cancer registry staff. And he has more than 30 peer-reviewed publications with over 2,000 citations. He's written 3 book chapters and over 60 posters presented in national and international conferences. And he's been the principal investigator for his site for more than 30 industry-sponsored and population health-based clinical studies. His areas of interest include evaluating the role of AI in healthcare, healthcare disparity, and health services research. So thank you very much for being here with us today.
Thank you, Juliet, and thank you, Georgia, and the registry for providing me this opportunity. Before we get started, are you seeing the presenter view, or are you seeing the full slide?
I am seeing the full slide.
Full slide, okay.
Yes.
Works for everyone. Yeah, we can get started. All right. Okay, good morning, everyone. And thank you for all what you do. I definitely feel appropriate cancer staging and the role of cancer registry is a very pivotal and important as part of our treatment for our cancer patients. So thank you for what you do. So today I'll be talking about diffuse large B-cell lymphoma. This is commonly abbreviated as DLBCL. So just if you're not able to slide, so just let me know. You're seeing the second slide, right, Juliet? It's transitioning well?
Yes, I can see that
Okay.
second slide.
All right, very good. So the most of the talk I've featured around the staging, the diagnosis, and the complexity of the DLBCL. Non-Hodgkin's, it falls under the broad category of non-Hodgkin's lymphoma, and it's one of the most aggressive types of non-Hodgkin's lymphoma. Non-Hodgkin's lymphoma itself is a very broad category of over 100 different subclassifications. But the DLBCL accounts for about 30 to 40% of adult non-Hodgkin's lymphoma cases, making it one of the most frequent diagnosed subtype. It is aggressive and it is rapidly grows rapidly. DLBCL characterized by rapid growth, cell growth, and can develop de novo, and that's what most commonly we see their presentation. Or it could be from a background of slow-growing lymphomas. That's another important distinction. We can have CLL or some slow-growing lymphomas. CLL can have what we call it as Richter's transformation, in which at some point your LDH goes high, patient becomes very symptomatic, has fever, and then what we find is a aggressive type of lymphoma, mostly in the DLBCL. Also, when you do a PET-CT scan, we will see a very high SUV uptake when there is a Richter's transformation. It is still very potentially curable, and with the new therapies and agents that are coming, the number we say for all comers without any stratification, it is potentially curable with standard therapies, with the first-line therapies up to 60 to 66%. And if with autologous stem cell transplantation, with CAR T cell therapy, the 5-year survival has really improved in the last few years, or in the last decade for sure. I would now be talking a little more about the treatments. I have some slides around that, but wanted to focus mostly outside of treatment and the discussion for DLBCL. Incidence and epidemiology overview. Annually, there are about 5 to 7 cases per 100,000 people globally, and about 18,000 new cases in the US itself. The median age at diagnosis is around 60 to 65 years, and males are slightly more affected than females. So again, a little bit difference. One of the common, so you have non-Hodgkin's lymphoma, you have Hodgkin's lymphoma. In Hodgkin's lymphoma, you have a bimodal age distribution. So between 15 to 30, there is an increased incidence of Hodgkin's. And then later in the you see another peak of in Hodgkin's. But that's not the case for most non-Hodgkin's lymphoma, and also for DLBCL, as it's just one towards the later half of their life is when you see the incidence of this disease. Most of the time, we do not know what causes, but there have been some risk factors which have been associated. Again, the most common risk factor is age. As the population ages, the incidence of cancer increases. There are some risk factors. For immunosuppression has been implicated, some autoimmune disorders, prior infections, and a family history of lymphoma confers a little bit slightly higher risk of developing lymphomas as well. So this has been an active area of research in the last 20 to 30 years. There is, as I mentioned previously, there is a lot of heterogeneity within DLBCL, and we have tried to look into a little bit more deeper. So what you would clearly or commonly see in your path reports is the origin, or where we try to subclassify DLBCL into some other subgroups. And I'll talk about that. So it again, at the end of the day, these are all develops from mature B cells. and either from the germinal or post-germinal center stage. There are genetic rearrangements. So the key mutations are BCL6, MYC or MYC, CMYC, and BCL2 rearrangements, and they drive molecular changes in DLBCL. So later on, I'll talk about double hit and triple hit lymphomas. So these are the three markers, and readily they might not be available on a path report, but there will always be an addendum. Hey, I've sent it all DLBCL. We should be doing further FISH analysis to really see if this BCL6, MYC, and BCL2 are present or not. So there is some distinction. You call it MYC positive if there is first they will do by IHC, immunohistochemistry, whether if there is a more than 40% expression of MYC on the lymphoma cells, then they will, or most instances right now, it's most of the pathologists or hematopathologists will send it for reflex testing for all these three mutations to make sure that for these changes, so that we are able to subclassify DLBCL a little better. And then there have been many active oncogenes which promote cell proliferation while apoptosis inhibition. So those are the hallmarks of any cancer cells, and also immune evasion, which allow for tumor growth. And that's why the whole BITE cells and CAR T cells become very effective treatment strategies to overcome this cancer cell strategy. Okay. So as I was talking about the molecular subtypes in pathogenesis, most of them, pathology or hematopathology, will not stop at saying just this is DLBCL. They will further subclassify either germinal center B cell or GCB, commonly abbreviated, and they make about 50% of the cases, and they generally tend to have a better prognosis. The activated B cell or ABC type is about 30% and generally tends to be a little bit more aggressive. And now we have some strategies for other than R-CHOP in this category, the ABC, which can be a little bit more effective. So that is another strategy that we have. Again, we use what's called as a Hans algorithm. So you will see stains for CD10 and all these things, which help to classify germinal center B type versus ABC subtype. So that should be coming to by pathologist. All right, I saw a chat. Okay, I'll answer those questions a little in the end. Okay. All right. The genetic alterations in pathogenesis. The key genetic alterations include BCL2, BCL6, and CMYC or MYC rearrangements, and the TP53. TP53 associated with chromosome mutation is kind of a bad prognostic marker across all malignancies. There was a Cell article from 1992 talking about how TP53 mutation, any cancer which has TP53 is generally associated with worse outcomes. And in general, solitary BCL6 is associated with good, but if you have with BCL2 and MYC, it becomes a triple hit lymphoma that confers adverse prognosis and can influence treatment strategies as well. So double hit is if you have BCL2 and CMYC positive, triple hit if you have all the three positive genetic rearrangements and a link to aggressive disease and poor outcomes. So that is an important distinction. It's not DLBCL, it will be DLBCL, germinal center, or ABC subtype. And then subsequently, the path reports generally, once they do additional testing, FISH and other things, they will come up with whether it's a double hit or triple hit lymphoma. Right. So that's how you will see more mature pathology reports coming from hematopathologists these days. All right. So WHO DLBCL subtypes. Again, there is still, has been work in progress and keeps coming with different subclassification, but this is like a very overall overview. DLBCL, NOS, several histology variants with unique features. There are some other subtypes as well. Some can include T cell or histiocyte rich, primary CNS lymphoma, PCNSL, or can be a subtype of that. It tends to be an aggressive with localization only in the brain. Sometimes you can have peripheral or outside the brain DLBCL and with CNS involvement. Cutaneous leg type, I have a patient currently on that. It's a very rare and tends to be very aggressive as well. And then you have, again, intravascular DLBCL. So each with very distinct clinical manifestations. And then sometimes you have associated when you have a DLBCL, some pathologists will work up to see if it's EBV positive. Sometimes it's associated with chronic inflammation and some virus like HHV8, which have very typical like primary pleural effusions. Those are generally associated with HIV, and HHV8 tend to be again very aggressive and generally impacts people who are elderly and immunosuppressed. So those are some various subtypes. We talked briefly about Hans algorithm helps to distinguish between germinal center versus ABC subtype. CD10, BCL6, and MUM, those are utilized. Again, that's a standard process for pathologists. So you will be asked, you will see these things in your report, but you don't have to decipher. The patient, the pathologist will come up with based on these. If CD10 is positive, then it's GCB. If negative, then you do BCL6 and subsequently MUM1 to come to a diagnostic. At some point, it could be, there's 20% of patients that we won't be able to get an answer whether it's ABC or GCB. It could be we were not able to get to that. More commonly and more so, what we are seeing is now gene expression profiling. It provides a greater accuracy, identifies lymphoma subtypes, and aids prognostic assessment for patients. So that is more and more upcoming. And guided targeted therapy, it helps in as well molecular classification, helps to guide targeted therapy choices and kind of improving personalized treatment strategies for lymphoma patients. So if you have a ABC subtype, if you're if you're stage 2 and higher and you have an IPI score greater than 2, then now there is more evidence that instead of the common medications like R-CHOP chemotherapy, there might be a case to be made for Pola-R-CHP chemotherapy regimen. So that's how we're telling. That's why we have subclassification of these patients. And then again, if there is an ABC subtype, then you will be thinking of more after the treatment. If there is some getting your transplant team and seeing how we can further keep the patient in remission. So working in partnership with other teams. So that's prognostic also, it has some implications. B symptoms, these are not exclusive to DLBCL. This is for all lymphomas. They include unexplained fever, profuse night sweats, not just night sweats. Living in Arizona, people can have night sweats, but it's profuse night sweats in which the patients have to get up 1 or 2 times and change their clothes. So that is, and significant weight loss, which is generally quantified as greater than 10% loss on the body weight. So those are, if patients have these 3 symptoms, we say these are the B symptoms. B symptoms then as a B suffix after the staging and helps determine severity. Patients generally with B symptoms tend to do a little worse than those who do not have B symptoms. But also the key is if patient is in remission and we have not done any scans and then B symptoms come, that's also an indication that the cancer might be, there might be a recurrence coming. So that is some of the ways that we utilize B symptoms staging. And critical implications for prognosis and influence important treatment decisions for patients. And sometimes, especially not in DLBCL, you would naturally treat them, but in other low-grade lymphomas, where some follicular lymphomas we do not treat right away, we might just observe the patient. But if these B symptoms become debilitating and affects patients' quality of life, then a case can be made to treat for those follicular and low-grade lymphomas. In general, we do not sit or observe DLBCL. They tend to be very aggressive. We treat it right away. Other constitutional symptoms, there are other symptoms which are associated in general with lymphoma, but more so with DLBCL, fatigue, weakness, itching can be a common frequent symptoms in many diseases, but they are not classified as B symptoms. Sometimes pruritus, alcohol-induced, patients classically define that whenever they drink alcohol, they have pain in those enlarged lymph nodes, and fatigue as well. So alone do not affect disease stage or staging criteria, but those are common symptoms as well. Early satiety and appetite loss is also very common in patients with constitutional symptoms. Sometimes you have to be careful because splenomegaly, that's an organ that sits behind the stomach. If it's enlarged, then it presses on the stomach and you have early satiety. So early satiety can just be a symptom of your lymphoma, but also could be because of the splenomegaly as well. So it's important to make that distinction. Yeah, we come to the IPI, prognostic index. This is also, I think, a very key important factor. And then we have newer IPIs coming as well. So the classic gold standard has been the IPI, or International Prognostic Index. It's based on 5: age, Ann Arbor stage, serum LDH, your performance status, and extranodal site or of involvement with lymphoma. And each adverse features adds a point, gives a point. So it helps to classify patients into risk groups for prognosis. It helps predicting outcomes. I do make sure that most of my patients, all of my patients, we are able to have an IPI score before initiating treatment. So that's why staging becomes important. It helps in outcomes and predicting appropriate treatment plans for lymphoma patients as well. So that is important. So based on your score, you're into 4 risk groups based on that, which help in predicting survival. So I know this slide doesn't show that well, but so your 4 groups are low risk if your IPI score is 0 or 1, and your 5-year survival is over 75% with your standard treatment. Then if your IPI score is 2, then you fall into the low intermediate risk category. The survival decreases to 50 to 55%. High intermediate risk category, IPI score 3, further decreasing your survival by 10 to 15 points. And the high risk category is 4 to 5 IPI. This is the subgroup of patients that tend to do poorly. Right? Also, just be aware that this is historical data in terms of their 5-year overall survival. And this is based on entirely on R-CHOP or some even chemotherapy regimen. But right now, there are newer regimens that we have used, and there are subsequent good effective treatments that are available. So this overall survival should not be entirely accurate. I think we have done much better as a field to push this at least 5 to 10 point higher than what's shown over here. Yeah. I'm not monitoring the chat right now. I will try to answer those questions. If you have any clarification at this time, you can come off mute and we can talk if you need any clarification. So, yeah. All right. Any questions so far?
We do have a couple of questions.
Yes.
But we can save those until the end, I believe.
Okay, got it. Okay, very good. And the pace is going okay, or all right?
Absolutely.
Okay, awesome.
Thank you. Good information.
Sure. Yeah. And what I really have most of my patients are I do is an NCC and IPI. I think it has a little bit better in most of the newer clinical studies for DLBCL. You will see that the NCC and IPI score is used as a more better prognostic marker. So it does assign same again, the usual suspects, age, stage, LDH, ECOG, but it kind of risk stratifies age into 3 different categories and other things. So it is a little bit more granular way of looking at your risk factors. So assigns again age, disease stage, LDH, ECOG, and extranodal sites. And LDH is also not just high or low as NPI. It is 1 time higher, greater than normal, and greater than 3 times normal. So that is how the disease is classified. This model increases prognostic accuracy and helps to predict patient outcomes more precisely, and also can customize treatment plans and inform patient counseling about the lymphoma care. Yeah. So based on this, you can have, again, 4 different groups. Yeah, you can have a low risk group, score 0 to 1. And as you see there, 96% 5-year survival rate. But they make only 25% of our cases for all new DLBCL patients. Then the second category is low intermediate risk group, in which the patient score is between 2 to 3, and survival is still good, 82% 5-year survival rate, and about 40% of our patients fall into that. So majority, as you see, are now having better prognosis. Then the third category is the high intermediate risk group, score ranging between 4 to 5, and now the survival starts to dip in this. So 64% 5-year survival rate, and about 25% of all cases of DLBCL will be in this subgroup, and in this fall into this subgroup. And unfortunately, the most higher risk group, which scores more than 6 or greater, and has only a pretty dismal survival of only 33% of 5-year, but thankfully only 10% of the cases fall into this high risk group. So this is the current NCC and IPI score. I hope most of the oncologists are using this or risk stratifying and have got into NCC and IPI as opposed to your IPI. So I would be very curious to learn from you guys also later on when we open for chat as to, are you seeing these things in your oncologist notes or not? Okay, clinical presentation, as expected, lymphadenopathy, 1 or 2 major lymph nodes. Sometimes also it's important is like, yes, one group of lymph nodes get involved, but over time they can become matted and then come across as one group. So it's important to be aware of that as well. Initially, they tend to be painless, rapidly enlarging lymph nodes, and disease affecting organs outside the lymphatic system can also happen. You can have B symptoms as well as some complications. If it is the thoracic lymph nodes in this mediastinal and other things, they can cause then direct compression of the superior vena cava and cause facial swelling and what we call as a superior vena cava syndrome. Similarly, if it's a lymphadenopathy around the spinal cord, it can cause spinal cord compression of the nerve roots and cause symptoms as well. There's some very unique extra nodal involvement. I know we'll talk a little bit about doing a bone marrow biopsy in the era of PET CT scan. The role of bone marrow biopsy is decreasing, but I always make a point to offer it to my patients and have that discussion with them. Then there is a CNS involvement, which is a specific category called as primary CNS lymphoma. So that is one unique presentation and tends to be pretty aggressive, but very, very responsive to chemotherapy. Then you can have liver, spleen, and another one is a testis involvement, which is also very unique presentation of testicular involvement. And in those cases, you want to give CNS prophylaxis to your patients and as part of your treatment. Yeah, nodal disease, typically as a painless lymph node enlargement, it most commonly in the neck, axilla, groin, and sometimes it can become matted together as well. Extranodal GI involvement, very commonly a subtype is also gastric DLBCL, which is causes pain and bleeding. So actually the presentation of the patients is GI bleed. And then when we do the endoscopy, we find a mass in the stomach and biopsy shows DLBCL. And the CNS can cause a neurological deficit, can present like stroke-like manner, can present like headaches as well. Yeah, bone disease can present as painful fractures. Testicular enlargement can happen, and the skin involvement comes as nodules or rashes on the skin. Again, very rare, but tends to be a very aggressive presentation of DLBCL. Diagnostic approach, very, very important, is for diagnosis of lymphoma, not just DLBCL, but across all lymphoma. FNA or fine needle aspiration biopsy are not the preferred modality. We really encourage to have core needle biopsy. The pathologist will be still asking for more tissue sample because it is important. You need to look at the tissue around its surrounding. The gold standard is excisional lymph node biopsy. So you take the full lymph node out, generally done by surgeon. But not all our cases, I would say, is excisional lymph node biopsy. Most of the time, we are making our diagnosis on core needle biopsy. Yeah. So, but in general, the gold standard should be excisional lymph node biopsy because you want to look for these architecture of the lymph nodes and in relationship with the cancer. So it is important to have wherever possible an excisional lymph node biopsy. Other lab testing then you would do is histology and the BCL6 and the MOC and all those things that we went previously around subclassification are all done by IHC. And then more and more molecular studies are coming. Flow cytometry would be, or if a fresh tissue sample is there, you would run a flow cytometry analysis as well. One very important consideration, especially across all lymphomas and also for CNS lymphoma, is if the patient has had like corticosteroids treatment in the prior to biopsy, then it can really impair your best results. So there might be some necrosis already because corticosteroids is part of most of our chemo regimens. It is a medication which has anti-cancer properties and also was one of the first medications to be used for the treatment of lymphomas. So just be aware that it's not an easy diagnosis, but also it becomes much more challenging if patients have been on corticosteroids. It really makes very challenging for our pathology colleagues to come up with the appropriate diagnosis. So try to avoid as much as we can. The pathological findings are diffuse proliferation of large lymphoid cells, nodal architecture, effacement, high mitotic rate, which is also you will see on your path reports quite commonly a Ki67, which is a marker for proliferative index. So a high Ki67 upwards of 50-60% are generally very suggestive of an aggressive as opposed to an indolent lymphoma. In solid cancers, the Ki67 tends to be less than 20 or maybe 20 to 30. Some breast cancers, it can be very high as well. So it is, but most of the indolent cancers, it should be less. But classically in DLBCL, your Ki67, which is the proliferation index number, tends to be more than 50-60% as well. Yeah, you will see these on the on the pathology reports. CD20, which is a pan B cell marker, hallmark, your medication rituximab, which is one of the most commonly used treatments for lymphomas, is an antibody against the CD20. Then you have CD79A, PAX5, are all essential for identifying B cell population in tissue samples. Cell of origin, we talked about CD10, BCL6, and MUM1. They help to classify between GCB and ABC subtype. And then Ki67 is used to evaluate cellular proliferation rates, as I've just discussed. Now, more and more reports you will see with molecular diagnostic techniques. You have FISH for the BCL2, BCL6, and MYC. You have karyotyping, and then you have TP53 mutation analysis also. And then NGS panels can deliver other important diagnostic and prognostic molecular data as well. So these reports initially might be a few decades ago, just 1 or 2 pages. Now they become like a 14, 15-page report that we have to go through and make sure that we have all the information. It also increases the turnaround period for everything. So lymphoma in general, DLBCL tends to be an aggressive lymphoma. Sometimes when you see a patient and you do all the workup and everything, these tumors are increasing rapidly. You need to start treatment soon. So you can't really wait for all the reports to come back. So most commonly, in the interest of time, we might start a patient on R-CHOP chemotherapy, which has been a gold standard for all the years, and then adjust accordingly when all these reports are there. Then you can make. So you always say to the patients that I'm still waiting for these results to come back. It's a possibility I might change your treatment, although not ideal, but just giving for one cycle so as to get the disease burden a little lower, and that is very acceptable practice. So PET-CT in disease management is considered now a very important and gold standard for staging, are accurately and assessing response to treatment also. In my practice, generally, prior to starting treatment, we do a baseline PET-CT scan. Then anywhere between after cycle 2 to 4, we do a second interim just to make sure that patient is responding. And some of times, like if they have very bulky lymphadenopathy, after your first cycle in 2 to 3 weeks, things start to melt away. So you will have some clinical judgment already, indication that patient is doing well, and the lymphadenopathy is decreasing, they are responding. But it's always a good to make sure that all areas of concern are decreasing, and then there is no heterogeneity in response, and also to make sure that there are no new lesions or surprises that we see. So and then at the end of treatment, we also tend to get a PET-CT scan after completion, or 3 to 4 weeks after completion of treatment, just to make sure that the patient is in complete remission. So that's how I utilize PET-CT, and that's how most of them utilize as well. So you are pretty much aware, but it identifies metabolically active disease, both nodal and extranodal, and helps in accurately staging. And it also helps sometimes if you don't have a diagnosis, although most of the PET scan we do after a diagnosis of lymphoma. But if you have not had a diagnosis of lymphoma, or sometimes you're following patients with follicular lymphoma or low-grade lymphoma, and then the patient becomes very symptomatic, say he or she develops profuse night sweats, fever, a lot of B symptoms, is losing weight, then you do a PET-CT, and then you will see that there is some SUV which are very high, 20 or 25. That is not how high a follicular lymphoma patient should have an SUV. So you tend to target those sites for biopsy to document a DLBCL or an aggressive lymphoma. And key times are baseline, interim, and then end of treatment for comprehensive response. I must admit, we do have challenges in getting all the 3 PET-CT scan approved by insurances. So sometimes we can, I think the next one is about a CT scan. Yeah, so if we do not we don't suspect bone disease, if we have challenges around PET-CT approval, a CT scan and a bone scan can be pretty acceptable options. And MRI has some unique indications as well. So contrast, again, for evaluation of lymphadenopathy, you should always have a CT with IV contrast. It becomes a little challenging if patients have renal insufficiency, then do not bother to do for staging a CT without IV contrast. The gold standard is PET-CT, but a CT with IV contrast is the acceptable replacement. Without CT, without IV contrast is not good. You should not be banking on that scan for initial diagnosis and staging. Okay. So contrast CT scans evaluate disease extent, organ size, masses, chest, abdo-pelvis. Okay. MRI, very specific for CNS and spine-related issues, and they can give a very good detail of the soft tissue as well. Sometimes even in the spleen or liver lesions or kidneys, MRIs are better. They will help you classify very appropriately how many lesions you have. These are, again, alternatives to PET if PET is not available. Okay. The lab testing, pretty standard. You get a CBC. If you see anemia, thrombocytopenia, and low WBCs, it's an indication of bone marrow. So that makes it more important to then obtain a bone marrow biopsy. More and more programs or oncologists are not offering bone marrow as an initial. Sometimes it takes logistically to get the bone marrow done. And also, if the PET CT is clean and you do not have any cytopenias, then it is an acceptable standard to forego a bone marrow biopsy at this time. Metabolic panel assessment is important to have baseline kidney and liver awareness. Electrolytes, especially calcium, is also important, and it's unique in DLBCL. Through the vitamin D pathway, they can cause hypercalcemia. So you need to be very cognizant of your baseline calcium levels. And also tumor lysis, because it tends to be a very aggressive disease. Any aggressive cancer responds very well to chemotherapy as well. And so you want to make sure you have LDH, uric acid levels. And if they are high, in my standard practice, almost everyone gets allopurinol ahead of starting their anti-cancer treatment only for the first cycle. So they should start the allopurinol 5 days ahead and then continue for 7 or 10 days after the treatment, so as to prevent damage to the kidneys or from tumor lysis syndrome. So you will be checking your phosphorus, LDH, uric acid, potassium levels, and calcium levels also. And that's important to have those ahead of time as well. And screening for infectious disease is important. Hep B, Hep C, HIV also. Some of these lymphomas are what we call as AIDS-defining illnesses. So if we have some lymphomas, then you're not only HIV positive, now you're classified as having AIDS. So it's important. And some HIV is a risk factor for some lymphomas as well. Hepatitis B and C, also most of the times we treat these patients with rituximab, which has a black box warning that it can cause Hep B reactivation and permanent liver damage. So it's always prior to starting rituximab, we check for hepatitis B. So you will see. And TB, although we're not so endemic, but you elicit a history. And if there is an history, you have to do quantiferon just to make sure that the patients are not at additional risk factor for developing TB during their treatment. Echo or a MUGA is another diagnostic test that we do prior to starting chemotherapy, and especially if patients are going to receive anthracycline, which most of the common first-line regimens have anthracycline as part of their. ECG can be recommended, but not really needed. As long as you have a good echo and a MUGA scan, you should be okay to receive anthracycline-based chemotherapy. One important aspect is the American Society of Clinical Oncology has as part of their guideline that any male or female below age 50, if they're receiving chemotherapy, no matter for lymphoma or any time, we should counsel them about fertility. So that's important. And any woman in the age, childbearing age, we need to have a pregnancy test prior to administering chemotherapy. Another marker over here is beta-2 microglobulin. That's a marker for, again, can help for prognostication as well, and then also for a follow-up. So beta-2 microglobulin and LDH can be used after treatment as a surrogate marker for, like a tumor marker for follow-up or surveillance. All right, bone marrow, as discussed before, it is an important aspect right now. Some oncologists feel that we can forego this test if the PET-CT does not show bone involvement and if the CBC does not show any cytopenias. So I still have that discussion with my patients at this time, whether they want to have a bone marrow or not. Generally, we are sending them for a port. So at the same setting, it's easy to get a bone marrow as well. Mentioned cytopenia. Also, it's important because sometimes patients might have low-grade lymphoma that you might find on the bone marrow. So there is some advantages or role for bone marrow biopsy. And both bone marrow aspirate and biopsy are performed, and then you will send it for flow cytometry analysis and further workup. So there is, in terms of treatment, I'll not waste too much, spend too much time over here. CNS prophylaxis, there is a subgroup of patients who are there can be a case in part of treatment that we need to give them prophylactic treatment to the CNS to prevent any penetration of the CNS with the lymphoma cells. Some of them are like high LDH, HIV positive. If you have neurological symptoms, you do testing and other things for that. All right, now we come to Ann Arbor staging. It is the gold standard, still a gold standard after all so many years. Stage 1 is considered to be a single lymph node region, or it could be a single extranodal site. If there is an extranodal site, then we use E as after the stage. So B is for B symptoms, E is for extranodal, and then X is for bulky disease. So those are the other modifiers after the 3 modifiers. Okay. Stage 2 is equal to or greater than 2 lymph node regions on the same side of the diaphragm, or localized extranodal site plus lymph node. So that is stage 2 or stage 2E. Stage 3 is above and below the diaphragm, and stage 4 is diffuse involvement of extranodal organs. So it's important. Bone marrow up stages you from 3 to 4. There is liver and lung or as well, other organs. So again, hallmark of staging for lymphomas has been standard for many, many years. Modifiers we talked about, if there's no B symptoms, it could be A, but generally we do not put that, or we can put that. If there's B symptoms, we put B. E is for extranodal and X is for bulky disease. So definitely this has to be, you cannot think even of treating patients before you have your appropriate classification. Not going to spend, Juliet, how are we doing on time? Can you?
You have about 16 minutes.
16?
Mhm.
Okay, all right. Yeah, I've kept I will kind of breeze through these slides a little rapidly. R-CHOP remains as a gold standard, has been a gold standard for more than 2-3 decades now. The 5 medications are rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. Previous to that, it was the CHOP regimen, and then in the 80s and 90s, rituximab became an important player. Then it became a R-CHOP regimen. There were many studies giving R-CHOP every 14 days versus 21 days. That came back as the 21 days is a winner. Initially, we were doing for 8 cycles, then we reduced to 6 cycles and found that 6 cycles is equally as effective as 8 cycles. So all those things sorted out. So right now, R-CHOP every 21 days for 6 cycles is the gold standard for treatment for DLBCL. I have not put, but as I mentioned earlier, if you are more recent data in the last 2-3 years is if you have ABC subtype or you have stage 2 and more are like DLBCL with IPI score of 2 or greater than 2, then there is another regimen called as polatuzumab R-CHP regimen that is available. So that is instead of vincristine, we have substituted that with polatuzumab. So that is another acceptable option or treatment option available for our patients. The approval is for not only ABC subtype, it is for all DLBCL. But if you do subgroup analysis, and again, you can debate whether that's a fair thing to do or not, what they found is the greatest benefit is for patients with ABC subtype that will benefit from the Pola R-CHP regimen. So I've not included in my slides, but I just want to make you aware that is still another treatment option available. So R-CHOP gold standard. Again, for limited early stage disease, you can just get away by doing 3 to 4 cycles and then involve field radiation therapy, a great prognosis. For advanced stage 3 and 4, you can do R-CHOP, or as I talked about, the Pola R-CHP. CNS prophylaxis we had touched on before. So high-risk patients who have testicular involvement, breast, adrenal, kidney. Kidney was another one. If you have kidney, then you need CNS prophylaxis. The CNS prophylaxis, I prefer the high-dose methotrexate, but you could also do just intrathecal chemotherapy as well. So there is not one over the other. It is different institutions feel differently about which is the best modality. But the data is more favoring to doing high-dose methotrexate. PET response assessment, there is the classical Doyle criteria is used in the Hodgkin's realm, but there is one for non-Hodgkin's as well. You have complete, partial, stable, or progressive disease in the interim or the end. Yeah. This is another very exciting area of chemotherapy, the second line and salvage regimens. So if the patient is still, if there is first relapse of DLBCL, you can either be CAR T cell options are available, and then there is a role for autologous stem cell transplantation with these chemo regimens prior to that. There's still prognosis still remains pretty good after that. This is indications like autologous stem cell transplant can still have 40 to 50% long-term survival. Okay. Very, very excited about CAR T cell therapy. Again, CAR T cell is not a product that I can use in my rural community in Yuma, Arizona. It is still a referral to a transplant center in Phoenix, San Diego, or Tucson. But several CAR T therapies are approved in blood cancers, relapse and refractory DLBCL. They have been available. Overall response rates pretty good, 50-80%. And about 40 to 50% can have complete remission, and some of these can be very durable complete remissions as well. So I'm very excited about CAR T. The one that we were very successful implementing is the bispecific antibodies, or commonly called as BiTE therapy. So sorry. So BiTE, again, not as intense as CAR T cell or stem cell transplantation, but more and more community programs are now able to do that. So it does have very unique cytotoxic toxicity. So you do need a lot of education, a lot of training to do this, but it is an important agent that is available in second line, third line, and beyond for our patients. And again, if patients doesn't have the means to travel and cannot do that. So we implemented a BiTE program and 3 of our patients have received the BiTE therapy in the last 6 months. So great. There are many 3 or 4 agents now approved as combination with polatuzumab, or just Epkinly or epcoritamab is approved just by itself as well. Polatuzumab is another. It's a targeted. It's a dual antibody. It is antibody drug conjugate, and it's been approved for like 5 to 7 years. Have been pretty good adoption within the community. And then these are the listed other targeted agents. Yeah. So prognosis, again, getting better every year, I would say, with more and more therapies coming on. It is, you do have to take into account the IPS score, the cell of origin, the BCL2, BCL6 double hit, and then the response to PET-CT scan. So it's not just one size fit all, although I just presented our job, there is still a lot of intricacies or thought process that goes on for treatment and managing these patients. Follow-up and surveillance for the first 2 years, if it's every 3 months and then 6 months and then every 6 months and then annually. You can have after 5 years, if you're cancer-free, very rarely a DLBCL will come back. Unless it was on a background of low-grade follicular lymphoma, then there is a chance of the follicular lymphoma almost always comes back. Surveillance, you do physical examination, lab test. The CT scans, there is still debated right now whether you need to do any, unless in my practice, I generally do it if patient is symptomatic or if patient has stage 4 disease to begin with, then I might do bone marrow biopsy or CT scans if there is some cytopenias or symptoms. But mostly it is surveillance is physical examination, lab tests, and imaging only if there is symptoms. That has been my practice. There is long-term implications. There is cardiac health. Some of these medications are cardiac toxicity. There is a what we define as a cumulative toxicity dose for anthracycline. The standard regimen gives you receive about 300 milligrams of anthracycline, and your lifetime dose is around 400 milligram per meter square. So if you had chemotherapy for something else in the past, then you have to be very careful. Your risk for cardiac diseases becomes significantly high if once you go beyond the cumulative lifetime dose of 400 milligrams per meter square. If you receive any radiation, there's a role for radiation for residual disease, or if you have a bulky disease greater than 7.5 centimeter, then there is a role for consolidative radiation after the end of treatment. So that also helps or can cause some cardiac issues. It was near the cardiac, around the heart if you're radiation. You have to screen for new cancers. Unfortunately, the incidence of newer malignancies or myelodysplastic syndrome, AML, and skin cancers are higher down. And there is still, although your chemo might get over, you're still immunocompromised for about another year or so from B-cell depletion. So recommend flu vaccine, COVID vaccine, HSV vaccine for these patients so as to prevent any harmful effects of these preventable diseases. All right, so key takeaways, still a most aggressive and non-Hodgkin's lymphoma, but potentially curable. I would say right now the cure rate, 5-year survival is 75% easily for these patients. First line CHOP has remained a standard. Now Pola-R CHP is another standard first line treatment after like 2 or 3 decades. And that's something new we have. We have diagnostic and evolving therapies. PET-CT scan remains the gold standard. Stem cell transplantation, CAR T cells, and bispecific are really exciting newer emerging treatments. And then molecular profiling is now crucial for this stratification in DLBCL. All right, I do have some questions, and again, Juliet, we can do that later. Happy to open the forum right now, and I can watch the chat and try to, however you want to handle it right now, do look at the questions or, yeah, let me know.
Wonderful. And thank you again so much for sharing with us this morning. I know I learned a lot. Excellent presentation. So we do have a few questions, and again, continue to add them into the Q&A chat if you have questions that come up as we're doing this Q&A. First of all, what clinical criteria do you evaluate to determine that a patient needs further workup for a possible diagnosis of diffuse large B-cell lymphoma?
Yeah. So it's a little tricky because by the time I see these patients, most of them have had the diagnosis of lymphoma or DLBCL. But having said that, we do run what we call as a high-risk clinic for our primary care providers. So if the primary care providers feel that, hey, this smells like lymphoma, looks like lymphoma, but we don't have a tissue diagnosis, one of our nurse practitioners, Bridget Allen, sees the patient right away. And then we work very aggressively with our surgeons, IR, to expedite the workup of that patient. And what we have seen is the time from initial suspicious imaging to the first treatment. Because of that program, we were able to reduce by 18%. So there is some value in an oncology or an oncology cancer team expediting. But also in 50% of the cases, we find TB, we find sarcoidosis, and not necessarily cancer all the time. So coming to the question is, what means like persistent lymphadenopathy, fever, B symptoms. So that would be an indication to continue working. Sometimes first core needle biopsy does not give you the correct what you're looking for. Repeated biopsies, excisional biopsies. If one core is negative, then we really press on our surgeons to do a excisional biopsy. And then, yeah, so those are the symptoms. There are things that we'll be looking continuously so as to keep workup of that patient. I'm not sure if that was a question, or if someone who posed the question can come off mute or ask for clarification. I'm happy to answer that.
That makes perfect sense. And as you mentioned, a lot of more chronic lymphomas will transform into that more aggressive diffuse large B-cell lymphoma. So would it mainly be the patient's symptoms to say, hey, they've had this lymphoma for years, and now we want to do further workup to see if it's transformed?
Yes. So the few things happen is like most of them, they might not need treatment. So these are small indolent lymphomas that we will be monitoring over time. Then you start to get, and patient might be relatively asymptomatic. Then the patient starts to get very high fever. When you do your blood work, you see high LDH levels. That would be kind of makes you a little concerned that needs a little more further workup. If you do a PET CT scan, generally for low-grade indolent lymphomas, the SUV should be between 4 to 10. But if you have seeing very high SUVs greater than 20, that is very suggestive of, no, this has transformed to an aggressive or a diffuse large B-cell lymphoma. And then we push or nudge our IR colleagues to then biopsy those sites for that. So those are, and then rapidly enlarging lymph nodes. That's also another thing that will be coming. And newer lymph nodes over time, they have seen, hey, this is the neck one, which is on and off, slowly growing. But now they're saying, oh, I feel in my armpits, new ones coming up. That's also another indication that maybe the switch has happened at the like the cell level, and now we are looking into a more aggressive type of lymphoma.
That's very helpful. So when we see that in the medical record, we know to maybe look for further workup at that point to see.
Yeah.
Excellent. Thank you so much. So on the other end, something that I know sometimes I struggle with, how do you, in the clinical setting, determine that a patient with diffuse large B-cell lymphoma has no clinical evidence of disease or is in complete clinical remission?
Yeah, that's a good one, right? Yeah. So your scans are important. Generally, between cycles 2 and 4, you do an interim scan. And most instances, you would be very lucky to find a complete remission. But it is a PET-based evaluation. If you find a complete remission on that interim scan, you don't even have to repeat a scan at the end of treatment. You still complete the 6 cycles of treatment, but you don't have to repeat a scan if the interim scan is there. most instantly, and especially when we see that patients have had bulky disease. The initial SUV was around 20, 30, and then after interim, it went into 15, 16. Now we still see some residual mass over there, but the SUV is less than 3, around 2.5. And what we do will helps is it tells you whether it's below the baseline. So they use mediastinum and the liver as your baseline uptake, and that's how the Duvel criteria would be. So you in the PET-CT reports, you will see baseline from the liver or the mediastinum is SUV of 4. So anything less than that is basically your body's own metabolism kind of rate to what you're seeing on SUV. So if you see an SUV less than 3.5 or 4, that means it is dead necrotic tissue. It'll take time. Sometimes you might still see a tissue out there, but it's not active cancer. So, but again, if you have bulky disease, then that's the case, then you consolidate that with radiation. There's still, again, some school of thoughts, some experts feel that there's no role for radiation. Some still feel that in bulky disease, you can, at the end of treatment, you can still do a little bit of radiation to help for consolidation as well. So that is there. But yeah, you're looking of end of treatment PET-CT scan, you might still see some mass, which was like, hey, 8 centimeter, now you see 2 centimeter, but the SUV uptake is very low, then it is considered to be like a complete remission that time.
Very interesting and helpful. Thank you. So we had a registrar ask, I have questions on the survival rates for double expressor ABC DLBCL. The information repeatedly calls it a poor prognosis, but possibly due to a smaller population, I find it difficult to find numbers. Is there any correlation between this type of lymphoma and the occurrence of other specific malignancies?
Yeah, there's no correlation between these subset of aggressive versus other, but I do agree. Means these numbers tend to be very smaller. And again, you are getting salvage treatments and other things. So I would put them under the very high risk category, and with the survival less than 30% for these high risk categories at this time. So 5-year survival, 30% or less. Again, it's not double hit is different than triple hit, and triple hit is different than generally the ABC considers to be the worst outcomes, but double hit would be worse. And then again, there are some like diffuse large B cell of the lower extremity. Those are also the skin. This tends to be again a separate risk category. So I don't have subgroup to subgroup good survival numbers, but I would say on if you pull them all together, it would be 5-year survival less than 30% or so at this time for these categories, all pulled together.
Thank you. And then the final question that I see is, do all patients need a stem cell transplant after treatment in order to be considered cured? Or is there a criteria that they have to meet? Obviously, age plays a role to be considered for stem cell transplant. Or are there any other factors at play?
Yeah, great question, Daniel. So we struggle as to which patients, especially living in a rural community, we don't have very easy access to transplanters. So it is an ordeal for our patients to then go to Phoenix, San Diego, or Tucson to get that consultation. And they ask, do I really need this? So in general, for my low risk or intermediate risk, I do not send them for a consultation. And if they are at the end of treatment in complete remission, still that number, it's 62/3 of them are cured and they would never need any further treatment for DLBCL. If it was on a background of low-grade lymphoma, then we would make a case, hey, maybe see a transplant team, because the low-grade lymphoma is going to come back at some point. The category, which is the high risk or intermediate, high intermediate risk, or the worst, or double hit lymphoma, triple hit lymphoma, I generally, my common practice, I ask them to go and meet with a transplant team so they will know what a transplant entails. It's also capturing them for both CAR T cell therapy as well as a transplant. So the evaluation by the transplant team is there. They might look into like all the, if there's a patient have a social support to undergo transplant, has the logistics of coming over here, getting heart evaluation, they need a pulmonary function test. If the patient is already a bad COPD patient, then he or she is excluded. So all those things can happen. So it gives you a little bit more educated information as to whether the patient, that treatment modality is available down the line or not. So that way, that's how I do it in the high risk, the poor risk category. But not all ABC subtype I will send for a transplant evaluation. It's only the ones that have double hit, triple hit, and all those are the ones that we would be sending. And again, if someone does not have a complete response at the end of treatment, that by itself is an automatic referral to a transplant team.
Makes sense to try and get them to complete remission if we can. I do see one other question, and that is, how accessible is CAR T therapy, given that it tends to be expensive?
Yeah, the cost of a CAR T therapy can be anywhere between 200 to 500K. So it is, I agree, it is expensive. It depends on the patient population that you're serving. Logistically, coming from in the Phoenix areas, Tucson, very readily available if the patient has good social support and is able to handle that treatment. It's CAR T is still, I would say, this toxicity and other things very unique. ICANS and all those things are in the realm of a transplant, whether the patient can undergo transplant or not. So it is pretty toxicity wise. Again, when you have patients from remote Arizona, like Kingman, Yuma, you have to rely a lot on logistics and other things. Sometimes access will provide transportation. Then we have a person to be there with the patient during that time. The drug companies are making it more and more easily accessible. So like one of the companies has a portal where you sign the patient up, and then logistically they will take care of everything else. I think the socioeconomic status, the insurances and other things do predominate the selection of patients, whether we would be able to successfully get CAR T or not, and also the age. Younger patients more so. When you're 65, 70 and above, less likely. But it can be done, but that then the percentage of patients getting that can start to decrease or trickle down very rapidly. So patients can get it. Again, your usual challenges, whether social support, economic means, whether you have someone who can be with you during the 3 months away from his or her work as a family member that can be there. If more than 40% of your population is at or below the poverty line, then it becomes much more challenging to find that someone else to be with you for 3 months for that treatment. So those are the challenges of the real world.
Well, we so appreciate your time and your willingness to share your knowledge with us. These cases can often be challenging for us to look through as well. So wonderful information. And I'll continue to monitor, and we can always send you after the fact any other questions that come up in the chat. So thank you so much again for sharing with us this morning.
Sure. And the slide deck has 2 very simple questions. Should be, even in the middle of night, if I wake you up, you should be able to answer those. So yeah, right. Thank you very much. Really very engaging dialogue. So I appreciate the opportunity, and thank you for having me. Thanks a lot.
Well, it is our pleasure. And next up, we have Dana Doyle, who's our Arizona Cancer Registry epidemiologist. And I've introduced her a little bit, but I will let her go ahead and share her screen and share anything else she would like with us. Thanks, Dana.
Hello, hi everyone. I'm Dana Doyle. I'm the Arizona Cancer Registry epidemiologist. I've been with the registry now 3 years, and this is, I think, my 3rd time doing a presentation for our annual workshop. And so this is a very brief presentation, only 1 slide, just to kind of give some state-specific information to follow up Dr. Chandra's presentation. But my full presentation on the overall Arizona cancer burden will be in the 3rd session, like Juliet had mentioned in the beginning. So today, just going to kind of take you through some Arizona-specific info for diffuse large B-cell lymphoma. And Juliet, can you just confirm that you can see my screen?
I can see it.
Perfect. All right. So this is what it looks like for Arizona. So this information for diffuse large B-cell lymphoma, it's not publicly available by state. So we thought it'd be really great to be able to provide this in our annual workshop and kind of give some context following Dr. Chandra's presentation. So in Arizona, looking at the past 5 years of available data, which is for us 2018 to 2022 right now, we can see that we have approximately each year on average 545 diffuse large B-cell lymphoma cases diagnosed each year at a rate of 5.9 cases per 100,000 Arizonans. And you can see in that top left graph, this is those incidence rates by year. So in 2018, we had our highest rate at 6.4 cases per 100,000. Between 2018 and 2019, that 1 year, we saw a drop of 12.5% in the rate. And we do see some fluctuations throughout those 5 years. But going from 2018 to 2022, we saw a 6.2% decrease in the rate of diffuse large B-cell lymphoma cases being diagnosed in Arizonans. And moving on to the graph in the top right. And so this is looking at incidence rates by race ethnicity. And in Arizona, white Hispanic individuals have the highest cancer rates for diffuse large B-cell lymphoma at 6.7 cases per 100,000 individuals, closely followed by white non-Hispanic individuals at 6 cases per 100,000. And I wanted to point out just some differences is that white non-Hispanics have a little over double the rate of this cancer type compared to Black and African Americans in Arizona. And then going down to our bottom left graph, this is looking at stage of diagnosis. So for the purpose of this presentation, for a stage of diagnosis, we group it into 3 categories. So early stage, which is our in situ and localized, and then late stage, which is our regional and distant cases. And of course, unknown is when we did not receive any information regarding staging for those cases. So for diffuse large B-cell lymphoma, we see approximately 68% of our cases being diagnosed in the late stage for Arizonans. And we know that stage of diagnosis is an indicator for prognosis and survival. And so looking at, this is now national data, not Arizona specific, but we do see that about 62% of patients survive 5 years after their diagnosis if there is no bone marrow involvement. And if there is bone marrow involvement, that survival percentage decreases down to 10%. And that is for people who have survived their cancer diagnosis 5 years after being diagnosed. And then the last graph that I have for you is looking at age-specific rates. So this is looking at the number of cancer cases per 100,000 people within a specific age group. So on the bottom axis, you can see we've broken it down into 5-year age groups. And we also want to show it by sex. So looking at male and female, the teal bar is male and female. The males are represented in orange and females are represented in beige. And you can see that across the age groups, the older we get, the higher our risk for cancer is. And we do see that reflected in our incidence rates for this cancer type. And like Dr. Chandra said, that males do have a higher incidence rates compared to females, and we can see that across the age groups, except for when we look at those ages 85 and older. We do see at the very last minute a flip from females having the higher diagnosis rates compared to males. But overall, looking at median age of diagnosis for Arizona, we match what the national median age is, which is 70 years old. So that is all the information that I have for you guys, just kind of some snippets of looking at Arizona specifically, and then we'll go into our top 5 cancer sites in the 3rd session. So Juliet, I'm going to stop sharing my screen, and if anyone has any questions, feel free to put them in the Q&A or follow up with me directly. So I will pass it back to you, Juliet.
All right, thanks so much, Dana. And I'm always fascinated looking at those statistics to see how we match up nationally. So you all should be seeing my slides right now. And I am going to cover the actual coding portion and how we take those bits of information that we've received and actually code them in our cancer registry abstracts. So again, feel free to keep asking questions as they come up. And I mentioned this in the chat, but you may want to pull up the heme manual and also summary stage, the current version of the summary stage manual, and CRRX if you want to be able to follow along with my coding of these case scenarios. So first, I just want to review the objectives. And so we've already done our review of diffuse large B-cell lymphoma as a histology, and Dr. Chandra talked to us about the background and the clinical symptoms. We've talked a bit about staging, and I will get into staging a little bit more with our case examples. We've talked about some current treatment modalities and what the new and up and coming advances are, and that's very exciting. And now we are going to, and Dana told us about the most recent 5 years of incidence and mortality data. And now we're going to look at the practice coding scenarios and take some actual de-identified DLBCL cases and see how we would code them. So that is the intent of this portion of the presentation. So I just wanted to go over a few of our fields that we can pretty consistently code when we know that we're looking at a diffuse large B-cell lymphoma case. So the histology is going to be 9680/3, and there are many, many alternate names for diffuse large B-cell lymphoma. So you can look them up in the heme database, and I do strongly encourage you when you're looking at these heme cases to actually go to the heme database and pull up that histology. You can search by histology, you can search by diffuse large B-cell lymphoma, and take a look at those alternate names so you can recognize them when they show up. And also spend a little time looking at that transformations from section in the heme database. Because as we mentioned, and as Dr. Chandra alluded to, there are many chronic forms of lymphoma that end up becoming diffuse large B-cell lymphoma. So I know coding primary site is also a challenge. You're going to want to look at module 6 and 7 and work yourself through those PH rules in order. And I've actually got my heme manual up right here behind my slides. So if we need to do that, we can. But basically, you can see on the heme manual page that diffuse large B-cell lymphoma is listed right here under module 6. And if none of these rules apply, then you can look at module 7 to be able to determine how you code the primary site for these cases. And you can look at the histologies and see that diffuse large B-cell lymphoma is also included in this module. So we just want to go in order and work our way through to find the right primary site. Grade is not going to be applicable because this is a heme and lymphoid neoplasm. And if you were to go to the grade manual, then you would find that these lymphomas are given a grade of not applicable or 88. So we need to start thinking about these lymphoid neoplasms and the cell type lineage, as Jennifer Ruhle is going to talk about hopefully in a couple of weeks. That's how the new version of the heme database and manual is going to be organized. So diffuse large B-cell lymphoma, it's right there in the title. It's a B-cell lineage, and it can present in the lymph nodes, but there's also very common extranodal presentations, including bone, testes, the spleen, Waldeyer's ring, the salivary glands, thyroid, liver, kidneys, and the adrenal glands, among other sites. And determining nodal versus extranodal involvement is going to help when we get to summary staging these cases. So what do we know when we're trying to code summary stage? Well, according to the lymphoma module, because you want to make sure that you're using the correct module when you're summary staging, any mention of terms like fixed, matted, or mass in the hilum, mediastinum, retroperitoneum, and or the mesentery, or any palpable, enlarged, shoddy lymph nodes or lymphadenopathy are all regarded as involvement when we are summary staging. And I'm not going to go through AJCC staging for these cases because the ACR does not require AJCC staging. But again, if you are required to AJCC stage diffuse large B-cell lymphoma because of being college approved or for any other reason, you want to make sure that you're using the correct module in the AJCC manual when you tackle these cases. So what else can we know about summary stage? If there's peripheral blood or bone marrow involvement, it's going to be distant as your summary stage. And for these cases, codes 0, 3, and 4 are not applicable. So I'm not entirely sure if you get an error message if you try to code those, but we know from the summary stage manual that those codes are not intended to be used for these cases. And then, of course, we need to remember that scope of regional lymph node surgery needs to be coded as 9 for these diffuse large B-cell lymphomas. So just very briefly, how do we know in the absence of our clinicians telling us what the treatment plan is, what the likely course of treatment is going to be for these patients? Well, we do have the NCCN guidelines that give us a hint as to what our physicians may be thinking in terms of treatment. And I'm not going to spend too much time here either, because Dr. Chandra did a wonderful job at discussing what the recommended treatments are going to be. But this is pulled directly from the NCCN guidelines, and it lists some of the first-line therapies that they may typically use. And you can see that it is broken down by stage and sometimes by the extent of that disease. So you've got one list for stage 1 and 2, excluding extensive mesenteric disease. And you've got another list for stage 2. Obviously, cardiac concerns, whenever you're talking about chemotherapy, come into play. So as Dr. Chandra mentioned, they do an evaluation for cardiac compromise in these patients, and there may be a different recommended regimen if these are patients with poor left ventricular function. And then it doesn't matter what the stage is, because that treatment decision is being driven by the ventricular function. And then if these are older patients, greater than 80 years of age, or they're very frail for other reasons, or they have some other comorbidities, then they might be recommended these regimens on the right-hand column of this list. So I think that's helpful to know that we do have these resources to give us some guidance on what to look for in the medical record. All right, let's talk about SSDIs. And again, I'm not going to say much about these because we already had some detail in the earlier portions of these presentations. But what we code in cancer registries, we code the presence or absence of B symptoms, and I've got them listed here from the SSDI manual. And they are a prognostic factor, and you're going to want to document any mention of B symptoms in the text PE section of the abstract to make sure that you've got documentation that matches how you are coding that site-specific data item. And another site-specific data item that we code in the registry is HIV status. And diffuse large B-cell lymphoma is one of several cancers that can be associated with human immunodeficiency virus, or HIV. So that's one reason why we track that. You're going to look for a physician statement. And if you have a physician statement of HIV being present, then you can document that in text PE. Or if you have lab tests available, obviously that's going to be preferred. And you would text that in text labs because it's specifically a site-specific data item and you want your text to match your codes. And as we heard about earlier in this presentation, another site-specific data item that we code is the IPI, or the International Prognostic Index. And they're given points, as Dr. Chandra mentioned to us. We only record that for non-Hodgkin's lymphomas, which diffuse large B-cell lymphoma is. And we don't record RI stage. I don't think I've ever seen that in the medical records for non-Hodgkin's, but if you do, just know that this is specifically where we're going to code the International Prognostic Index. And it includes all of those criteria that I've got on this slide and what we learned about earlier today. So, okay, let's look at specific case examples. And for our first case, In the history and physical, we find out that this was a patient who was transferred to this facility for further workup of fatigue and respiratory issues. They had anemia and thrombocytopenia on lab work. There were no B symptoms. They're a never smoker, and the PE was negative for palpable lymphadenopathy and for hepatosplenomegaly. So these are the kinds of things that we're going to want to look for and note when we're abstracting these cases. And that should hopefully show up on the physical exam. And they're going to be concerned about that when they're making their diagnosis for these patients. So imaging was done, and the imaging confirmed when they did a CT of the chest, abdomen, and pelvis that there was no supraclavicular or axillary lymphadenopathy, no mediastinal or hilar mass or lymphadenopathy. The spleen was mildly enlarged, and the liver was prominent in size. There was no bulky enlarged abdominal or pelvic lymph nodes noted on imaging. They did test for HIV, which was negative, so we know how to code that site-specific data item. They did a bone marrow biopsy, and that was positive for diffuse large B-cell lymphoma. And that involved 20 to 30% of the biopsy specimen in hypercellular bone marrow. And they also did immunohistochemistry and flow cytometry, which supported the diagnosis of diffuse large B-cell lymphoma. They did some genetic studies, and there was one metaphase with a complex karyotype. They did proceed to FISH, as we heard they may do earlier in the presentation, and it showed no rearrangement of MYC, BCL2, or BCL6, and there was no MYC fusion or IgH or CCND1 and IgH. Molecular studies were positive for those alterations that are mentioned on this slide, and negative for CXCR4 mutation. The patient went on to have treatment with cyclophosphamide, doxorubicin, methotrexate, and vincristine, and they were given dexamethasone and rituximab as well as part of their treatment plan. So how are we going to code this case? Well, here's how I coded it. Diagnostic confirmation was positive histology and immunochemistry. They did do some genetic testing, so it's more than just the histology. They confirmed those genetic traits to help them determine that this was a diffuse large B-cell lymphoma. The primary site, we have bone marrow involvement based on that bone marrow biopsy. We do not have any lymph node involvement, so I used PH26 was where I arrived, and again, I looked at all those portions of the abstract, including the physical exam and the imaging, to determine that the only known site of involvement here was that bone marrow. And again, grade is not applicable. Lymph nodes get coded to unknown because this is a lymphoma. Summary stage is going to be distant because we do have bone marrow involvement at the time of diagnosis. HIV status, we have HIV testing that we can use to code that field, and it was negative. This patient was specifically stated to be asymptomatic for any B symptoms, and there's no statement that would allow us to code the International Prognostic Index. We do have a biopsy of the primary site here. We did a bone marrow biopsy to get this diagnosis, so that gets coded. There was no surgery done, and in fact, it's not applicable for this particular primary site. Scope of lymph node surgery gets coded to unknown, as I mentioned, and you do get an edit when you try to complete the case if you code lymph node surgery to anything other than unknown based on your primary site. And there was no surgery to other sites either. Chemotherapy, there were multiple agents. There was hormone given, and when you look at CRRX, dexamethasone does get coded as hormone if it's being used to control white cell proliferation in hematopoietic diseases, and it gets coded as hormone therapy for lymphoid leukemia or lymphoid lymphomas or for multiple myeloma. So that's why that is coded the way it is. And the rituximab is immunotherapy, and you always want to look up anything that you don't know. Don't try to memorize these. Use your resources, use CRRX to code correctly, and you'll see that rituximab falls under immunotherapy. So that was case number 1. And let's see, since we've got some time, if there are any other questions about that case. I don't think I see any. All right, case number 2, and I tried to come up with a few different examples to show you. This patient presents, they have a history of follicular lymphoma, and that would be sequence 01 if you make your way through the heme manual, because this is a transformation, and we actually have the date of diagnosis that we can use our rules correctly, because it depends on how far apart these 2 diagnoses were made, whether or not this gets coded as a single or as multiple primaries, and we have to follow the rules set forth in our heme manual for that. The follicular lymphoma never required any treatment, and this patient now presents with right knee pain, and they do an MRI, and there was an interosseous mass, and the patient was negative for B symptoms, and there was no palpable lymphadenopathy or hepatosplenomegaly. HIV negative for labs, X-rays. They do several imaging modalities. They do an MRI of that right knee, and there's a 2.9 centimeter chondroid lesion posterior to the femoral metaphysis, and there's an adjacent destructive marrow replacing osseous lesion in the medial femoral trochlea. 1.9 centimeters there with the cortical breakthrough anteriorly, and there's extra osseous extension of the soft tissue component. They do a PET scan, a whole body PET scan. There's moderately avid left neck level 1 lymph node that measures at 1.1 centimeter. It's noted to be increased in size from the previous MRI. And there's a 9 millimeter focus of increased uptake in the left posterior nasopharynx and adenoid sinuses. There's no mediastinal lymphadenopathy. The spleen is normal in size. The mesenteric root shows a retroperitoneal mass, 3.2 centimeters, similar in size to the previous scan, which I believe is referring to that MRI that was done a couple of weeks earlier. And there are scattered sub-centimeter non-avid mesenteric root lymph nodes. There's a new intensely tracer-avid lucent lesion in the distal right femur, and there's no axillary, subpectoral, or inguinal lymphadenopathy. So they do a bone marrow biopsy in this case, and that is positive for an extensively necrotic B-cell lymphoma with germinal center phenotype. And they do genetic testing, and it says worrisome for progression to high-grade lymphoma, and immunohistochemistry and flow cytometry support that diagnosis. So they go on a few weeks later to do an open bone biopsy of that right distal femur lesion, and there's where we get the confirmation that we're dealing with a diffuse large B-cell lymphoma that transformed from follicular lymphoma, and it is listed in transformations in our heme database rather. And so then the timing comes into play when you're making your determination on number of primaries. They did FISH studies, and that reveals a BCL2 rearrangement without abnormalities in MYC or BCL6. Ki67 was elevated, highly elevated, and immunostains were positive for BCL6, MUM1, BCL2, and MYC rearrangements. So the patient was given cyclophosphamide, doxorubicin, and vincristine, along with dexamethasone and rituximab. So that seems to be a pretty standard treatment plan for these patients. So here's how I would code that case. Again, we have positive genetic studies done, and FISH was also done. So this gets coded the 3 for diagnostic confirmation. And the primary site, you have to work your way through the rules. And the rule I used was PH22 to arrive at lymph nodes NOS, because we have lymphadenopathy, so we can presume that those lymph nodes are involved, along with the bone marrow involvement of that femoral lesion. So the histology is going to be diffuse large B-cell lymphoma, because that is the most specific histology that we get. And the earlier bone marrow biopsy just said advanced B-cell lymphoma. So this is very consistent with what we're seeing. Tumor size summary is going to be unknown. And you see that grade is not applicable. Lymph nodes are unknown. It's distant a diagnosis because of that bone marrow involvement. And, oh, I did want to mention that these are going to be two separate primaries, the follicular lymphoma and the new diagnosis of diffuse large B-cell, because they were diagnosed more than 21 days apart. It's quite a bit of time between diagnoses of the chronic and the acute forms of these lymphomas. And sequence 01 would be C42.1 because there's bone marrow involvement of that when I looked into it. And the histology would be M9691/3 for follicular lymphoma. And now we're looking at sequence 02, which is this new diagnosis of diffuse large B-cell lymphoma. HIV status is negative. This patient was stated to be asymptomatic from the perspective of B symptoms, and there's no documentation of the International Prognostic Index. They did do a biopsy of the primary site. We have a bone marrow biopsy, and they were given multiple chemotherapy agents along with hormone and immunotherapy. So that is case number 2. And let's look at case number 3. This one is a little bit different, and I was glad I found this because, as Dr. Chandra mentioned, there are specific lymphomas that impact the brain, and as you're going to see, this is one of those lymphomas. So I was excited to have that tie in earlier. So this patient presents for a resection of a left temporal lesion. They have a prior medical history of hypertension and diabetes, currently on insulin to help manage that diabetes. They present to the emergency department with headaches, blurry vision, left ear pain, and generalized weakness. So all indications that there's some brain involvement going on here. They've been experiencing specifically left-sided headaches for around 2 weeks, and they endorse blurred vision, although they are able to identify number of fingers on exam. And they also complain of left ear fullness and pain, still with serviceable hearing and generalized weakness, but they are able to move all their limbs. And the PE was negative. So the plan is a resection of that brain lesion that we're going to see when I look at the scans, followed by chemo and immunotherapy. And I like that this physician actually documented what the treatment plan was going to be in this case. So here are all the scans that were done. There was an MR of the brain, which showed a 3.5 by 2.8 by 3.3 centimeter, fairly well-defined lesion in the left posterior temporal lobe. So that makes sense with the headaches that the patient was experiencing. Associated severe surrounding white matter edema or swelling in the brain because of this. And there's another similar appearing lesion in the left precentral gyrus, and that's new since the prior exam and highly suspicious for a metastatic disease. They also do a head CT, and that is roughly similar, and there is some growth in that larger of the two masses. It reached 4 centimeters in the month or so between when they did those studies, and that is identified within the post-temporal occipital junction, and it causes effacement of the atrium of the left lateral ventricle with very slight left to right midline shift. And they give you the amount of shift that happens because of the growth of that lesion in the brain. So they do an excision of that lesion in the temporal lobe, primary diffuse large B-cell lymphoma of the central nervous system. Histologic sections demonstrate a CD20 positive diffuse large B-cell lymphoma, and it co-expresses MYC and BCL2 proteins. They do FISH studies, and the FISH studies showed no evidence of MYC, BCL2, or BCL6 rearrangements, and the molecular studies confirm the presence of an MYD88 and L265P alteration. They also do a bone marrow biopsy about a week later of the left iliac crest, and that bone marrow biopsy was negative. That's going to become important later too, as we look at the primary site. They do a craniotomy for tumor resection, of the brain, and then they do methotrexate, rituximab, and in this case, temozolomide gets added in to the treatment plan. So let's look at coding this case. Here's what I did. Again, we have those genetic studies. Now, in terms of the primary site, what's important here is that we have no known lymph node involvement. All the scans, the physical exam was negative. There's nothing that we have in this chart that indicates lymph node involvement of this lymphoma. And in addition, they do a bone marrow biopsy. So we know that that's negative for involvement. So the only site of involvement is the brain lesion. And so that's why that gets coded the way that it does. Tumor size summary, we can code it in this case because of the primary site. And we use, of course, the largest measurement. Brain, we also don't have lymph nodes as applicable. We do, so those get coded as unknown. Summary stage is going to be localized because it's confined to that one site of the brain involvement. Brain molecular markers are not applicable for this particular histology, and they do not state those specific brain markers that we look at. So the surgery of primary site here is going to be an A300, the total resection of the tumor. We always have to be careful of that in brain because usually they're not removing a whole section of the person's brain because they need as much brain matter as they can have. So make sure that you're coding based on the resection of the tumor, not resection of a lobe of the brain or the primary site, because typically they're just going to remove that tumor. Chemotherapy, we have multiple agents, and we have immunotherapy as well. And that temozolomide they give is a clue too that we're dealing with a primary CNS neoplasm because that's where you most often see that. So that is my portion. Let's see if we have any questions that have come in for our live Q&A, because that's next. I do see one question here, and that is, if the physician documented CNS primary on this case, would you still use the temporal lobe or would you use CNS primary C72? I think we can be very specific because of those scans, and we know exactly what portion of the brain that this particular primary lesion is in, because the other lesion is mentioned a couple of times as metastases within the CNS system. So because we have that information, I feel comfortable using the more specific subsite in this particular case. That is the question that I see. We also had a hand raised earlier, so if that individual wants me to unlock their mic so that they can ask their question live, just raise your hand again. And I'll give everyone a couple of other minutes in case there are other questions that come up for me or for Dana and her portion of the presentation. All right, you can always email me with questions. I believe Dana provided her email address as well on the slides. So thank you again to Dr. Chandra. Thank you to all of our presenters today. And I hope that you will join us back next week for the second component of our workshop where we have different presenters and presentations, and we get to discuss some QA challenges and also some GYN cancer coding strategies. All right, I don't see anything else, so I will let you all have back the 15 minutes of your day. But like I said, feel free to reach out to us if questions come out in the meantime. And I hope you enjoyed today's presentations and found them valuable. So thank you again for being here and have a wonderful rest of your day.